time allows today. And we're delighted to have Dr. Susan Perlman joining us again today as our ataxia expert. Dr. Perlman is currently a clinical professor of neurology and director of the Ataxia Center at the UCLA Medical Center in Los Angeles, California. Welcome, Dr. Perlman.
Thank you. Thank you. And thank you for having me back. And thank everybody who's joined in here. I see a lot of familiar faces and names and a lot of people that I haven't met yet. And I think I can say firmly, as with every other expert you've had on here, that, you know, we learn a lot from research, you know, we're involved in research, but I think most of what I've learned about ataxia, I've learned from my patients and their families. A couple of questions came in prior to the session today from the Friedreich's ataxia community, but I think in general they can apply to anybody with ataxia. There was a question about vision involvement. In Friedreich's, there is a risk of vision loss due to optic neuropathy. The optic nerve can be affected by the genetic stressors that we see in Friedreich's. And in spinocerebellar ataxia, in the dominant ataxias, ataxia type 7 can also experience vision loss on the basis of retinal degeneration. So both of them, you know, can have significant loss of vision, either slowly over the course of the disease or more rapidly in the later stages of the disease. Certainly there are experts in ophthalmology that work with retinal degeneration and optic neuropathy. They have eye vitamins that they may recommend, retinal care of other types. You know, I went through the literature this morning and I found that, you know, in the case of Friedreich's and animal models of Friedreich's, that, you know, some of the antioxidants that have been in clinical trials may have a benefit in preserving vision. Idebenone is actually approved in Europe for vision in a disease similar to Friedreich's, where there is vision loss due to mitochondrial problems. So, you know, I think the majority of ataxia patients don't experience vision loss, but they may experience changes in vision, double vision, trouble focusing, that may require special glasses with prisms in them. They may, you know, need specialized, you know, computer screens. So, you know, if you have any vision problems at all that you feel may have been made worse or associated with your ataxia, definitely discuss it with your optometrist or ophthalmologist. And the other question from the Friedreich's ataxia community related to fluid overload. You know, for years, there has been, you know, discussion in the Friedreich's ataxia community about, you know, being careful if you're going in for a surgery or you're going into the emergency room. Don't let them put an IV in and give you lots of fluids. They're going to overload your heart with fluids. And I think in some cases that has led to tension in an emergency setting where somebody might have needed extra fluids because of dehydration. And the British ataxia group did have an information release discussing this. And there are some, you know, information points on the Friedreich's Ataxia Research Alliance, the FARA website as well, you know, basically saying that fluid overload becomes a concern if you have a heart problem. Now, this could be somebody with Friedreich's with the associated heart issue. It could be anybody who has a heart problem, rolls into an emergency room. The first thing they do is stick an IV in and run lots of fluids in. So I think, you know, good care by careful practitioners will not do that. They'll put in an IV and have it run very slowly to keep open in case they have to administer medication. But, you know, I think the general advice for somebody who has a cardiac problem is, you know, be alert. Make sure that your healthcare provider knows you have a heart issue and that they may need to be careful with how much fluids they give you or other medications that they give you. I have a patient with a form of non-genetic ataxia who had a tremor, and I decided I would start very low dose propranolol, a beta blocker. However, her underlying ataxia included problems with blood pressure stability, and even that very small amount of propranolol, caused her blood pressure to drop. So it's something I should have been aware of. I should have been, a little more alert to. Similarly, I have a patient who has ataxia, was complaining about a chronic runny nose, whether it was due to the ataxia or due to environmental factors. And I thought, well, let's go online. We'll look at the Mayo Clinic site. They have a long list of things you can use for a chronic runny nose, which was getting in the way of speech and eating in this person's case. So, there seemed to be one nasal spray that worked. He didn't really have seasonal allergies. I thought this would be a good choice for him. However, I remembered from his medical history, he had glaucoma, and certain nasal sprays are absorbed and could worsen glaucoma. So fortunately, I encouraged him to check in with his eye doctor before he tried this particular nasal spray. So, I think, we have many options to deal with a variety of symptoms in ataxia, but it's important for all of us to be aware of other health problems that we may have that could make a particular medication choice or treatment choice not ideal. So that's just a little summary of two questions that came in early. Now, Lori, are we going to go through the questions in order?
We can certainly do that. I did see down here, Christina, piggybacking off the vision topic, said that her double vision is increasing and she has prisms in her glasses, but they had to increase over the last 6 months.
With double vision due to incoordination or malalignment of the eyes, so the eyes just don't work together when you're looking forward or looking to the side or looking up or down. Prisms are helpful if your double vision is consistent wherever you look. You have them in your glasses and they realign the eyes, and then wherever you look, the glasses help you with that. If the double vision is more prominent looking to one side and not present looking to the other side, or it's prominent, looking close as opposed to looking far, or vice versa, sometimes prisms will not fully correct the problem. If your vision is very double and you can't have thick enough prisms to correct it, there can be eye surgeries that can help to realign the eyes. I've seen this in some of my patients with spinocerebellar ataxia type 3, Machado-Joseph's disease, where they'll have a corrective eye surgery, realign the eyes, they don't need the prisms anymore, but after another 5 or more years, the double vision may begin to creep back in. So if you are troubled by double vision, again, it's important to have a good optometrist or ophthalmologist who understands, a little bit about ataxia and eye coordination. If your double vision is due to nystagmus, you have the eye tremors when you look to one side, your eyes will shake, you look to the other side, your eyes will shake, and it can interfere with focusing, and it may give you a doubling sensation. The Osgood prisms will not help that, and that you may have to look more for medications that may be able to calm down the nystagmus or the eye tremor that is there. And I saw one of the questions related to the use of clonazepam. This was from Eleanor. Is clonazepam safe and effective for eliminating or reducing downbeat nystagmus and ataxia? 4-aminopyridine caused major seizures. There is a long list of medications that can be used symptomatically for nystagmus, and I believe they're on the NAF website. Clonazepam is one, used at low dose. Side effect can be drowsiness, so using it during the day can be a little tricky. But there are other medications that have been reported to be helpful for nystagmus. Baclofen, we think of as an antispasticity drug, but it has had some use in nystagmus. Memantine, we think of as a drug for memory problems in somebody with Alzheimer's, but the people at Johns Hopkins have demonstrated some benefit for nystagmus. Certainly 4-aminopyridine, Ampera in the branded prescription formulation has some history of success in downbeat nystagmus, but it does have a side effect of seizures at higher dose. So I think Eleanor should, explore with her neurologist other options and maybe go to the NAF website and see what the drugs are. It's a long list. And I've had people who've gone through the whole list and they still have nystagmus, but it's absolutely worth trying under supervision. And, it's interesting, the question following that from Danielle, can a treatment for inherited ataxia be used for acquired ataxia? Depends what the treatment is. If it's a treatment for symptoms of ataxia, of which there are currently no approved treatments, but a number of things used off-label, amantadine, Buspar, Riluzole are things that have been around for years for off-label use of improving balance and coordination symptomatically, can be used in inherited and non-genetic ataxias. Treatments targeting a gene mechanism obviously would be more appropriate for an inherited ataxia. Forms of ataxia, genetic and non-genetic, where there may be some secondary inflammation around the nerves that are deteriorating or under stress, certain anti-inflammatory drugs that are in the pipeline could be helpful in either case in slowing progression or improving symptoms. And I know that in the National Ataxia Foundation, Dr. Lauren Moore is putting together a pipeline of drugs that are in development for certain genetic ataxias, all genetic ataxias, symptomatic management of ataxia that will hopefully sort out the mechanisms so that we and our collaborating doctors, neurologists, and other physicians you may be working with can go to that pipeline and see, there's something, under development that could slow progression. This is something you should sign up for the trial. This is something that we could try off-label. So I believe that pipeline is going to be extremely helpful in sorting out treatment options, as well as options for involvement in clinical trials. Now, there was an earlier question here from an individual with episodic ataxia, SCA2 dystonia, and some symptoms of Parkinsonism. So I don't know what this individual's genetic diagnosis is, because episodic ataxia has, I think there are up to 8 separate genes now that can cause it. SCA2 is a very specific genetic factor. And then symptoms of dystonia and Parkinsonism may accompany certain ataxias, SCA2 and SCA3 specifically. So Ruth mentions that she's experiencing multiple freezing incidents in the middle of walking with no warning. She will suddenly freeze and, have to, control some body shaking until she's able to move from that location. She indicates that she has trouble recovering from that freezing episode and needs somebody to come along who can actually escort her back. Now, freezing is very typical of symptoms of Parkinson's disease, but also ataxia, where there may be involvement of the basal ganglia causing Parkinson's-like symptoms. So breaking that freezing is very hard. And Ruth indicates that somebody will come along and, probably, give her a little push or support her in some way, and then she'll be able to walk back to her original location, hopefully without falling. There are assistive devices. There's a walker, the U-Step walker, which has a couple of things that can be helpful for freezing. One of the things that's installed on that walker is a little laser light that when you get stuck, you press a little button, a laser light, a red light shoots across next to your feet, giving you a target to step over. And that can sometimes, in patients with Parkinsonism, not necessarily Parkinson's disease, they can use that little red light to step over and get going again. So that's one little trick that the Parkinson's community has come up with. Now, Ruth indicates that she's tried amantadine that seemed to make that worse. She has tried Artane, which is another one that's used for symptoms like Parkinsonism, stiffness, and dystonia, which seemed to help her stiffness, but didn't stop the freezing episodes. I think the best way to manage the freezing incidents would be, number one, if you have an assistive device, get it with that little laser cue. Number two, because the freezing comes from pathways that are controlled by dopamine, amantadine has some dopamine-related activity, but it seemed to make her worse, potentially because it has other activities. Artane, may not help with the freezing. It can help with the stiffness, but I'm wondering about a trial of carbidopa-levodopa, Sinemet, is commonly used in Parkinson's and may help reduce the freezing. So that, I think, could be a next option. The, greetings from South Africa. Hello. I'm just going down the list here. Jeffrey, what is the usual effective dosage of acetazolamide to control episodic ataxia type 2? This individual, Jeffrey, is taking 125 milligrams 2 times a day, along with 60 milligrams of Buspar. It's another one of the off-label ataxia drugs, originally approved for anxiety. The dose of acetazolamide can actually go much higher than what Jeffrey is currently taking. And I think the primary thing that limits it is side effects. When acetazolamide is used for altitude sickness, for, glaucoma, for other things, the dose could be much higher and should be discussed, with your prescribing doctor. But then the risk of side effects goes up. So, I had a visit from a gentleman with episodic ataxia type 2 recently, who is taking 125 milligram tablets, 1/2 of that tablet 4 times per day. He seemed to think that was a good range for him. And when he tries to increase it, he noticed there were changes in hearing. He got funny, prickly, painful feelings in his feet and hands. His eye doctor, said, well, gee, your eye pressure has gone really low, which could be good if you have glaucoma. But if you don't have glaucoma, there's an optimum range of eye pressure that you don't want to go too far below. So he is limited in his dosing, which is just about what Jeffrey is taking because of side effects or potential side effects. The other drug used in episodic ataxia is 4-aminopyridine, which is available as a prescription drug, a Dalfampridine, as a time release that is taken, twice a day, 10 milligrams in the morning, 10 milligrams in the evening. There's a compounded formulation where you can get smaller doses that are immediate release, 2 milligrams or 5 milligrams, depending on your compounding pharmacist. Again, not wanting to go above 20 milligrams per day. So if you have episodic ataxia or downbeat nystagmus or ataxia in general, Dalfampridine, either compounded or prescription, is a reasonable thing to try, on the list of, medications that are being used off-label. Now, some of the other symptoms that Jeffrey notes here, acute vertigo, unsteadiness, dizziness, disequilibrium, become more chronic symptoms as opposed to the episodic symptoms. And again, there's a long list of medications that can be tried off-label to control dizziness or vertigo or disequilibrium like you're on a boat. And the list of these medicines is on the National Ataxia Foundation website. And I would encourage you to review that. Okay, there is going to be a Trehalose clinical trial going on in the US. This is Kunji. It is sponsored by the Psilocybin company, who acquired the intravenous Trehalose from BioBlast, which was the original company a number of years ago that did a small introductory study, which suggested that intravenous Trehalose, bypassing the stomach so it doesn't get digested, could serve to break up the buildup of abnormal protein in the brain in the triplet repeat genetic ataxic disorders. So this trial is going to be for spinocerebellar ataxia type 3. It's going to involve weekly intravenous infusions of intravenous Trehalose. So it's going to be demanding, for time and travel. But it will be starting at a number of sites in the US. There are patients of mine who have been taking oral Trehalose, just regular Trehalose, which will be digested in the stomach, but there is some evidence in a study, I think, that was going on in Korea or in Taiwan, I'm not sure, that oral Trehalose, enough could be absorbed that it could get to the brain and could have some beneficial effect. The problem with Trehalose is it's a sugar. So if you're diabetic or pre-diabetic, it could alter your weight, it could alter your glucose metabolism. But this trial will be starting up fairly soon. Now, Hannah, what are the statistics of acquired ataxia progressing? Acquired ataxia could be acquired from any one of a number of vitamin deficiencies, head injuries, stroke. You figure if you acquired it from an insult and you control the insult, you replace your vitamins that are deficient, you do rehab to recover from a stroke, you should be on a stable recovery level that you will maintain ideally for the rest of your life. I mean, that's the way we think about this. However, once there is damage in a system, and we've seen this, another group of patients I've worked with for many years are survivors of polio. They had an infection, it did damage, they recovered from the damage as best as they could recover. You figure, that's it, they're going to be at that level, for the rest of their life. Well, two things can interfere. Once there is damage to an area in the nervous system, even if the cause of the damage is now under control, those damaged neural pathways can create a low-grade inflammation that may go on and slowly add additional damage over years from this very low-grade inflammation. And there is research going on in neural inflammation, drugs that may interrupt that in a variety of neurologic disorders. We also have the effects of aging, that as we age from about the age of 30 going forward, we are losing brain cells. So if we have an insult, we've controlled the insult, we've recovered to whatever level we're going to recover, aging is going to cause dropout of nerves in those pathways, and we will lose the recovery, or at least some of the recovery that we had. So it's expected over 10, 20, 30 years from a particular acquired insult that there could be slow progression that goes on because of aging-related mechanisms. But it should not progress at the level of speed that you would see in one of the genetic ataxias, where from year to year, over 3 to 5 years, you will notice change. Now, Carl has a question. My 36-year-old daughter has had cerebellar ataxia since birth. She was tested for inherited forms in 2001, and that's quite a few years ago, and all results were negative. Would it be potentially helpful to get additional genetic testing now? Yes. People who are born with cerebellar disorders more and more genetic factors are being found that underlie that developmental problem or that change that has been there the entire life of that person. And since 2001, we have developed better knowledge of some of these newer and rarer genes, and also better ways to test for them. So one good screening test is called whole exome sequencing, where you sequence the entire, coding genome, all your DNA that's responsible for making proteins, all those genes, to see if they look normal. Is the structure changed in a way that could be causing a defect in that gene, that gene's performance? Many of the genes that, we can identify with whole exome sequencing, we know are involved in targeting the cerebellum. Many genes that might pop up on whole exome sequencing, and one of our geneticists here said that all of us carry at least 6 gene mutations for things that could cause problems in our children if we married somebody else who carried the same thing. We might have a dozen changes that nobody really knows if it's going to cause any difficulty in that particular gene. It just looks a little different. And there are many genes that we just don't know what they do. So the data that we collect from whole exome sequencing or whole genome sequencing can help in the diagnosis of an ataxic disorder presenting at any age, and does open the door to the development of treatments that may be targeting that particular gene. So even though, upwards of 10, 15 years ago, when I would order genetic testing and, the insurance company doctor would call me and say, well, we're not going to approve this because it's expensive and it's not going to change your management. I think now, however, our knowledge of what these genetic pathways do and how we can intervene, it has gotten more insurance companies that are willing to, pay for genetic testing. For insurers that are just roadblocking, we don't cover genetic testing at all. I know the National Ataxia Foundation has been working on ways to make genetic testing available to people who are roadblocked like that. But there are genetic testing companies that can do simple genetic testing, more complicated genetic testing at a relatively reasonable price for people who must pay for it themselves. And I know that the National Ataxia Foundation, I think, has a list of those companies and what they're charging for whole exome sequencing, what they're charging for single gene testing, so people can make a decision to move ahead with testing if it looks like it will be beneficial to them. So yes, your last genetic testing was over 20 years ago. Time to update it. Francis Thomas. Is being extremely tired and fatigued common with ataxia? Fatigue is absolutely a part of most forms of ataxia. And it's either a change in central fatigue pathways, or it's the fact that your body and your brain have to work harder to balance, to move around if you have ataxia. Or you have a sleep disorder, which is relatively common in people with ataxia. All of these things can contribute. Deconditioning if you're not exercising. So for individuals with ataxia who are fatigued, one of the first things we do is we check their sleep, making sure that they're not having sleep apnea or inefficient sleep that leaves them feeling exhausted from the moment they wake up. Screen for other medical illnesses. If you're anemic, which many people are, they don't realize it, but it can be, an insidious cause of fatigue. Low thyroid can be a cause of fatigue, and deconditioning. So, it's important to have, some type of regular exercise that gets your muscles moving. Even if it's 15 minutes per day or half an hour every other day. It can be helpful in helping to push back against fatigue. And I'm sure there is research still going on to look for other causes of the fatigue in ataxia. Now, Peter, I was diagnosed with late onset ataxia recently. Are there any support groups in South Africa? Well, National Ataxia Foundation representatives. I think you've got a good list of support organizations around the world. And so I would say contact the NAF and find out who in your region, is running a support group. I think one of the only benefits of COVID, besides the brief time when traffic was not too bad in Los Angeles, is that we've become very used to remote Zoom interactions. I mean, this is my fourth Zoom visit or fifth of the morning. So, it makes it easy for people in any geographic location to get together, to share ideas, to speak to each other in a supportive environment. Maybe a little hard to do with 276 participants, but I know our Huntington's disease support group at my institution went totally remote, Zoom for 2 years. And they had very good attendance. Now they're opening up to in-person visits and trying to do, a hybrid model where, people can come in person or people can Zoom in. So I think, access to support activities via remote visits is going to be with us and will hopefully be beneficial, especially for people who live in remote areas. Not that South Africa is remote, but certainly, we should take advantage of any of this technology. Okay, Stuart, what is the expected longevity for a patient diagnosed with ataxia in her 70s? Depends what kind of ataxia. If it's an acquired ataxia, it should not interfere with longevity, as long as proper care is taken to stay mobile, avoid falling, avoid choking. And I think for anybody who, reaches, not that the 70s are that old, but who, develops ataxia or is living with ataxia over the age of 50 or 55, very important to avoid falls, avoid injuries, avoid choking. Many of the ataxias that present later in life will not progress rapidly. And the things that get you in trouble are things that are preventable. There are some late in life ataxias. Rarely the genetic ataxias will present late in life. And they will typically, pursue, have somebody become disabled within 10 to 15 years. If we're looking at, a typical time frame, where they might become wheelchair bound, for instance. If the late in life onset ataxia has any medical complications, I had a patient who had onset of ataxia at age 69 that turned out to be Friedreich's. And, even in that late onset form of the disease, there is a risk of heart involvement. So, I would say, the average person, with onset of ataxia, multifactorial or from an acquired cause, it won't interfere with normal life as long as they're careful about injury. Certainly, there are causes of ataxia later in life, immune system dysfunction, autoimmune problems that could cause, could progress very rapidly and cause significant disability. And even multiple system atrophy, which it's unusual for it to come on in your 70s, may progress more rapidly and cause more disability faster. So I think for Stuart, talking about this individual, diagnosed with ataxia in her 70s, the type of ataxia and the type of care is going to have a tremendous impact on longevity. Now, Laura's question, have I heard of negative reactions to the Shingrix shot by persons with cerebellar ataxia? Apparently she did have a negative reaction to the first shot, so she hasn't gotten the second shingles shot. had a mild case of shingles years ago. So some concern about, getting, I think any vaccine, certainly the COVID vaccine has generated a lot of discussion. Her movement disorders doctors in her plan haven't been able to answer, and I can't answer either. I have patients who have gotten the flu shot and have been laid up for 2 weeks with a flu-like syndrome. I've got, and I think we all have cases of people who've gotten the COVID vaccine and have had various reactions to it. I think, anybody who's had a bad reaction to a shot should be careful about getting a second, a flu shot next year or a booster. I would be cautious and weigh, discussing with your doctor, the benefits and risks of not getting the shot. I have not heard that the Shingrix shot causes irreversible decline in cerebellar ataxia. I think there is some concern that, getting shingles can be pretty bothersome. But, it usually clears up. I think there is some concern that getting COVID can lead to lingering symptoms that may not clear up. So when I have to make a choice for myself or my family, I will typically, go to the side of getting a shot. It's supposed to protect me. If I've had a shot and got terribly ill from it, I probably wouldn't get a booster, and I'd probably avoid, the flu vaccine, for instance, for a number of years. This kind of discussion is something that would be very lively in a support group, I guarantee you. And I don't think, that there's, any specific hard and fast rule about, if you're immunocompromised and your immune system is low, you shouldn't get a vaccine that has a live agent in it. Because, rather than stimulating your immune system, you'll get sick with whatever it was that they were immunizing you against. So there are certain ataxias where the immune system is affected, ataxia telangiectasia, and those individuals are warned, if they're going to get a vaccine, they shouldn't get a live vaccine. It should be a killed vaccine. All right, then Jeffrey again brings up episodic ataxia type 2 and a peripheral neuropathy with some fasciculations, some sensitivity, some sensory changes. I think, it's not necessarily, a part of the episodic ataxia type 2, although, many ataxias can involve other areas besides just the cerebellum. Comments that was concerned that the neuropathy, the paresthesias, the cold sensitivity was caused by long-term effects of medication, either Buspar or acetazolamide. And acetazolamide can cause symptoms like that. Buspar, not so much. Certainly, if you have developed symptoms that aren't clearly related to your ataxia, don't assume they're part of the ataxia. You're not immune from other disorders. If you develop, numb feet, and you have ataxia, don't assume that the numb feet are part of the ataxia. Maybe they are, but you need to connect with your doctor to make sure it's not something else, not a problem with circulation or an early sign of diabetes. Then Michael indicates our 8-month-old daughter was diagnosed with SCA8. Have I heard of any cases of an infant being born with SCA8 or other very young people? The youngest people I have seen with SCA8 have been teenagers. And SCA8 is predominantly ataxia. It doesn't have a lot of other symptoms associated with it, mainly the ataxia. Um, and we see it relatively commonly in older people in their 40s and 50s, but I do have some teens. I have never seen an infantile case of it, but I am sure if we go into the literature that somebody has reported that. So what I think you should do if you're seeking help with an expert, or seeking to connect with other people who may have an infant who was diagnosed with SCA8, and learning about clinical trials. All of these things, the National Ataxia Foundation and its website can help you, connect with experts, find the clinical trials that might have an interest in an atypical case like this, or to connect with other parents who have an infant with SCA8 or another infantile onset. There's infantile onset SCA5, there's infantile onset SCA2 and 7. So even if there aren't any other families with infantile SCA8, I think there could be other people that have shared that experience and can give you some advice about, finding experts, dealing with the condition, and seeking out clinical trials. Are there any upcoming clinical trials for SCA1? Yes, the Ionis company is developing a gene blocking treatment. And they're working on their clinical trial design right now. They had a survey that many SCA1 people participated in, where they could provide information about their feelings about clinical trials, what they would like to see in a clinical trial. And I think the National Ataxia Foundation has been at the forefront of making sure that the patient's voice is heard, that if a company is developing something, they need input from patients and families. So we'll keep our eyes open for this. Bladder problems, urinary retention. Jody, hi, Jody. Many types of ataxia will cause incoordination of the bladder. So you'll have a fast bladder. When you have to go, you really have to go. Hard to control bladder. But on the flip side, sometimes the nerves that supply the bladder can become weak and you have trouble emptying. So it can be one extreme or the other. And urology, just like cardiology, have developed many good ways to intervene and fix urinary problems, cardiac problems. Patients with Friedreich's ataxia and cardiomyopathy are living longer now because cardiology has gotten smarter in the way they intervene. Similarly, urology has gotten much better with working with people with neurogenic bladder, either a bladder that's too fast or a bladder that does not empty properly. Okay, Kunji has brought up the Antisense oligonucleotide trial, ASO trial for SCA3. This is similar to the trial that's being developed for SCA1 and potentially some of the other SCAs as well, where an antisense oligonucleotide that is similar to messenger RNA is injected into the spinal fluid, typically, circulates, identifies the messenger RNA that is making the mutant protein in SCA3 in this instance, and targets it for destruction so the protein is not made or is made at a lower amount. And Biogen is the one that is currently furthest ahead in developing such a trial for SCA3. The issues, I think, with antisense approaches is they're not specific just for the bad gene. They will block production of the good protein from the normal gene. And, I think there's still information we need to gather about how low you can go with a protein that's an integral part of what our brain requires. Obviously, we want to depress the bad protein so it doesn't build up and damage the nerves. But if at the same time we're depressing the good protein, could there be problems down the road? It's administered by spinal tap, which, monthly spinal tap every other month, every 4 months, still working out strategies for that. but it's an invasive procedure. So I think the technique, using this to block the bad protein that's being produced in these triplet repeat dominant SCA disorders is, an important and strong way to intervene, but there are risks associated with it, and those need to be discussed if you're thinking of enrolling in such a trial. Now, Alex has a son with what appears to be a fairly rare spastic ataxia. Only a handful of people have, been identified with these particular defects with no MRI. And I must admit, I don't know about this form of spastic ataxia. And, many times when I don't know something, and patients who see me in my office, we often spend a lot of time going online because they've asked a question I just don't know the answer to. But I'm pretty good at finding answers online, in the literature, or by asking other experts. So I am going to take a picture of Alex's question. And I'm going to go back and, after we finish our session today, I'm going to go back and do some research and see if I can find more information about that. Francis, is swelling of the feet, ankles, and lower legs typical? Okay. Swelling of the legs, if you sit all day, or you sit on an airplane for several hours and don't get up and move, I think everybody is going to get a little swelling of the feet and ankles. If you have problems with circulation, varicose veins, you're going to get some swelling that may become chronic and may not resolve. I think with the possible exception of Friedreich's ataxia as a common ataxia that could affect peripheral circulation, the average ataxian who develops swelling, it's either because they're not mobile enough, they aren't moving their legs enough, or they have another issue, a cardiac issue, which is probably the worst thing that could cause swelling in the legs, is if your heart isn't functioning well. So if you're noticing swelling of the feet and ankles and legs, the first thing you need to do is see your general doctor and make sure it's not something unrelated to the ataxia. And if it turns out that there's nothing else wrong, probably means you need to move more. Peter, I seem to have shakes and tremors when I am sleeping. Is this normal? Periodic leg movements of sleep, twitching and cramping and spasming of legs during sleep is common in the ataxia population. There are a lot of ways to intervene to relax that and prevent that from happening, whether it's, exercise, physical therapy related, or medications you can take at bedtime. If you have a tremor as part of your ataxia during the day, typically when you go to sleep, it will go away. So the nighttime shakes, tremors, cramps, and spasms are being, released by a different mechanism and are for the most part very treatable. So I would definitely recommend seeing your neurologist about that, for ways to control that. Jeffrey again brings up the problem of cognitive impairment as part of his ataxia, but part of ataxia in general. And I think we know from the research done by Dr. Jeremy Schmaman at the Mass General in Boston that the cerebellum coordinates speed of memory and thinking, just like it coordinates speed of hands and speed of walking, so that any cerebellar disorder might slow up your recall, could make it harder to multitask, and you just have to go a little slower. And you find ways to compensate for that. Any sudden memory loss, you would be concerned about something else, and specifically, a stroke or a circulatory problem. Sudden changes in any ataxia-related symptoms, whether it's the balance problem, whether it's a multitasking problem, any sudden decline, you think there's something else going on. you have an underlying infection, your sleep has been disrupted and you're operating, with a tank half full all day. You have another condition, another neurologic condition or medical condition, which is interfering with, memory and comprehension. And that should be investigated and shouldn't just be assumed that it's from the ataxia. What dosage of CoQ10 is recommended? How is CoQ10 helpful? CoQ10 is a cofactor for energy production in nerve cells. Nerve cells don't store energy. They have to constantly produce it. So energy production is very important for the nervous system and the cerebellum. And CoQ10 as a cofactor, can get into the brain and maybe can, speed up energy production a little bit. Oral doses more than 2,400 milligrams per day and potentially more than 1,200 milligrams per day, you're not going to get any more into your brain. There's kind of a limit as to what you can take orally and how much will cross over. So I think the average doses are somewhere between 800 and 1,200, and some people might take a little more. It seems to be helpful also for fatigue for some people, not everybody. So, I think if you were going to use CoQ10 as a trial for an anti-fatigue agent, very, very appropriate. If you were going to use it as a neuroprotective agent or an anti-aging agent, if you type in, Google, anti-aging supplements, you're going to get hundreds and hundreds of things, many of which may not do anything except empty your wallet. But, CoQ10 is near the top of the list. Omega-3 fish oil is near the top of the list. Vitamin E in modest doses, not overdosing, is near the top of the list. So, I think there are antioxidant neuroprotective supplements that may be helpful. And, the anti-aging research is helping us identify which ones are those. Steve, any studies of reversals with ataxia? The only ataxia symptoms I have seen go back to normal are some of the acquired ataxias when you identify the vitamin deficiency, or you identify, whatever the other issue is, you fix it, and often the ataxia symptoms will resolve, provided you haven't damaged all of your reserve. So I think it's important to pursue, certainly for acquired ataxias, but I'm thinking that with treatments that are in the pipeline for genetic ataxias or degenerative ataxias, where there may or may not be a genetic factor, but they seem to progress inexorably after the age of 40 or 50, I think there will be treatments that will allow us to reverse some of those symptoms as well. My experience with cannabis is that it's becoming one of the more commonly diagnosed genetic causes of ataxia in people over the age of 50. And it's important now that, people over the age of 50 who seem to have, no family history of ataxia, but have developed symptoms that are consistent with cannabis, in its full, presentation or even in a partial presentation, be tested for it. The problem is there's only one lab in the United States or in the world that tests for it. That's the University of Chicago. And they have currently stopped accepting insurance. They will not bill insurance. And I recently tried to send an order for cannabis testing on one of my patients, and they wouldn't even accept self-pay at this point. So I don't know what's going on with that lab, but I think it's important because of the frequency that it's appearing and the important research that's going on, that we find a way to get cannabis testing made available. National Ataxia Foundation, are you listening to this? That's one genetic test I think should go on your testing list of things you'll be offering to people. Okay, somebody mentioned blood pressure instability. Common in multiple system ataxia or multiple system atrophy, not a common feature of other forms of ataxia. And I'm sorry if I was a little confusing in the way I presented that. Is psilocybin mushroom helpful or harmful for spinocerebellar ataxia type 6? And my question to you, Adelaide, is where do you get psilocybin mushroom? I know back in the day, there were people on campus that seemed to have it, but I'm not sure where you can get it now. And I know that, agents like this psilocybin, let alone the mushrooms, are kind of being watched by, by the FDA, by the government, that they are potentially harmful. So I would be careful about using, I think there are, like lion's mane is a mushroom that a lot of people are using now that seems to be helpful for a number of symptoms of ataxia. But psilocybin, I would be careful of. Choking, Selena. Okay, so choking, easily, important to have a speech and swallowing therapy evaluation to figure out why you're choking. Are you choking because your throat is incoordinated? Are you choking because your throat muscles are weak? Are you choking because, like you mentioned, just breathing, you apparently can get saliva down the wrong pipe and choke. I think it's very important to have a swallowing evaluation done. If you are choking and it's not on a solid something that somebody could do the Heimlich maneuver and kind of pop out of your airway, one strategy that people who will have coughing and choking spasms on saliva is they'll close their mouth and then slowly breathe in through their nose. So mouth closed, slowly breathe in through the nose, and that seems for some people to be able to stop the coughing spasm, which can go on and can be quite frightening. Okay, Sue Wild. Progress of research that I was involved in at UCLA with a blood test for a marker of alpha-synuclein, bad protein that builds up in multiple system atrophy, which is a non-genetic ataxia. The group at UCLA and other groups working on this as a biomarker, research is still going on. It's not available as a clinical test. The diagnosis of multiple system atrophy or multiple system ataxia is still very much based on your clinical presentation and potentially on brain MRI results, that there are no commercially available biomarkers for diagnosing this on the basis of the alpha-synuclein protein, but that research is going on. And then Peter, how do I know if I'll be getting worse or I am able to maintain the condition? He's been exercising, not sure what it is in miles, but walking. We know that you can protect your brain with regular exercise. Cardio stimulates nerve growth factors, which protect the brain. A healthy diet, and there's a lot of debate about, what is a healthy diet. The Mediterranean diet often comes up. Appropriate use of supplements. We talked about vitamin E, CoQ10, and omega-3s. I think anything you can do that will, bring these little benefits in to try to shore up your ataxia will help you maintain better performance. In a genetic ataxia, despite the best, health habits, over time it will progress. Multiple system atrophy, over time it will progress, but you can maintain better performance, better quality of life by being just a little careful, with things that, are common sense, for most, people these days.
Well, Dr. Perlman, you've covered a lot of questions. We're at the top of the hour already.
Yeah, and I have another meeting and I apologize for that. And I'm scrolling through all
We
these
did
other
have one
amazing
question
Yes.
that from an attendee that wanted to stay anonymous, and I know you have to get going. His question was, does ataxia affect sexual desire?
Ataxia can affect sexual performance by affecting the small nerves that control erectile function in men, or, sexual responsiveness in women on a physical basis in that area of the body, so that, problems with sexual performance are relatively common, for many types of ataxia. I think, sexual drive and things that come from the brain itself, the limbic system and all those reinforcing pathways that, that control, sexual drive and libido, it may be affected. But there are many other things that can affect it. Depression can reduce sexual drive. And, you may not, think about depression. Nobody wants to think they're depressed, but it can, really make, many aspects of living with ataxia that much more difficult, including sexual functioning. So, if there is a problem at any level of sexual functioning, discuss it with your primary care doctor. Ascertain, is it, a physical nerve related thing? Is it a, brain pathway thing? Is it related to something, outside of the ataxia, and then work to make it better?
That's great advice, Dr. Perlman. Thank you so much for all the topics that you covered here today. I did put some links in the chat as you went along on where to find the medications fact sheet, the genetic testing options, and our global ataxia support group. And I know that there were some questions about if a recording of today's session will be available. That will be available to everyone. Thank you so much, Dr. Perlman, for being here. I know you have to run. And thank you, everyone, for joining us for today's session. Enjoy the rest of your day, everyone.
Okay. Take care.